Welcome to The Whole Pineapple. I'm Ruby Boris.
And I'm Ann Judge. The Whole Pineapple is a podcast about wellness focused around fertility. We'll talk with experts on a wide range of topics, including nutrition, stress relief, sleep, mental health, etc.
And we'll dig into the issues that can cause fertility challenges, like PCOS, or early menopause, or cancer treatment.
So if you're curious about your fertility, whether you're ready to start a family,
or you're preserving your options for the future, let's dig in. Well, hello and welcome back, everyone, for another episode of The Whole Pineapple. I'm really excited about today's episode. And what do we got going today?
oh my gosh, we're going to talk about, pelvic pain, which may not sound like the most fun topic,
so
but
fun.
It's something that is so common, and we have an amazing guest, and I'm really excited to have a good conversation.
Yeah, so I am going to go ahead and just jump right in and introduce our guest. Dr. Angela Hernandez is a pediatric and adolescent gynecologist at Seattle Children's Hospital. She completed her OBGYN residency at Baylor College of Medicine and PAG fellowship at Texas Children's Hospital in Houston, Texas. Her clinical interests include Mullerian anomalies, multidisciplinary care, complex contraception, and chronic pelvic pain in adolescents. When she's not at work, she enjoys going to Orange Theory fitness classes and exploring the Pacific Northwest with her partner James and their 2 dogs and their foster child. So exciting. Welcome, Angela.
Thank you.
We really appreciate you being here. Ruby knows this, but I saw you speak at a conference a while ago, and I was just blown away. I was like, oh, she managed to make what can seem like a dry topic really accessible, and it's something that is so important that we really don't talk often enough, especially when it comes to adolescence. So I'm really excited to have you be here with us today.
Yeah, thanks. I'm happy to be here.
Yes, and pelvic pain is something that a lot of people, especially those with uteruses and ovaries, deal with a lot. And sometimes they don't even know what they're dealing with is abnormal. And or maybe they do know it's abnormal, but they don't know what to do about it because it is kind of a complex process. But I feel like a lot of people, they're N of one. They're their own comparison. They have periods. They know they're not pleasant. They're awful, but it's normal for them.
Yeah. And unfortunately, for so long, people with uteruses have just been told that, your period is supposed to hurt. These pains are normal, and it's just part of life and something you have to deal with. And that's something that I'm trying in my adolescent population to really kind of demystify and get down to the bottom of why things are painful and see what I can do to help them.
And how do you define that? Like if you have someone that is either they're talking about it or maybe they're brought in by a parent, like what is a normal amount of pain versus what is something that really is a sign of something you should be worried about?
So the measure that I really use is pain that interferes with your day-to-day. So for your average teenager, I tell them their job is to go to school. Their job is to participate in the activities that they, are part of and to be a teenager, essentially. Mm-hmm. And if periods or pelvic cramping or pain outside of periods are so bad that it's interfering with their ability to do that, then it's time for us to interfere. So the technical definition of chronic pelvic pain is pelvic pain that's gone on for at least 6 months. Usually by the time they get to me, it's been going on for a couple of years. And so most of my patients do meet that definition on our first encounter.
Is it true that periods are more painful in adolescent period, or is that a myth?
That's a really great question. Ironically, the first year after starting a period, most people don't complain of cramps. Mm-hmm. So kind of patients who from the get-go start complaining about cramping in their cycles, that's almost like a warning sign for us that there might be something else going on, like a Mullerian anomaly, an obstructive anomaly, or something like endometriosis, because it isn't very typical for your teen who is new to menstruating to necessarily have pain. It's just one of those things people don't really talk about. I'm not too sure if adolescents, they're just new to it. And so they talk about it more with their parents, and their parents hear about it more. Their pediatricians, their family practice doctors hear about it more. But yeah, there certainly is pain with cycles.
And define a little bit, what are Mullerian abnormalities? I know that's one of your specialties, but for our listeners, what does that mean?
Yeah, so specifically in talking about chronic pelvic pain, where Mullerian anomalies or variations positions and how a uterus can be shaped. Some certain Mullerian anomalies can lead to painful symptoms, specifically when there is some sort of obstruction, whether it be at the level of the vagina or lower or, higher up from there, that can cause menses that should be going out the bottom to kind of go backwards into the abdomen.
And is that often the first time that someone would have any symptoms, when they are trying to have basically shut off a uterine lining? Before that, you wouldn't necessarily know, right?
Yeah, exactly. Sometimes people it's incidentally found if they're being followed by another specialty and get like surveillance ultrasounds. Usually it's renal ultrasounds that also find, some mysterious mass, and they're like, what is this? But most people don't know until they are at the age to start having periods, and it's not necessarily all coming out.
And that's another good question, because not everybody might know that. What is the average age to start a period? Because I think people are surprised about how big a window can be normal.
For sure. And, the average age of menstruation just keeps getting lower and lower because of other factors, obesity, hormones, etc. But as of right now, we usually tell people 11 to 12 years old. One of the ways that I like to prepare my patients is by asking them, their parents, their siblings with uteruses, how old were they when they had their periods? And that can kind of give you a good idea of when that child should undergo menstruation. Another kind of time that we can use is based off of when they start breast development. Generally, we say 2 to 3 years after breast development is when you would expect your first period to start.
And then what is endometriosis?
Ooh, that's a loaded question.
Since I just went to this Endocrine Society talk, there was a lot of talks on the source of endometriosis. So I'm sure a lot of our listeners have dealt with endometriosis, or they're dealing with fertility, and so they've heard of endometriosis.
Or if they're Googling pelvic pain, they've definitely read about endometriosis.
Totally.
Yeah, definitely. So endometriosis is essentially a chronic inflammatory disease, and it has really severe social, physical, and emotional impacts. About 1 in 10 people with uteruses are affected with endometriosis, and kind of the hallmark for their symptoms would be really bad pelvic pain, not necessarily just with periods, maybe also outside of periods. And then, in your guys' adult world, infertility.
And I think that's often one of the situations that it comes up. People don't realize they might have endometriosis until they struggle with infertility. And then you're taking this history and you hear about, oh, I had these really painful periods. I started on the pill when I was only X years old. And a lot of times people have been on the pill for a long time. And so it's only when they go off of it to try and get pregnant and have a return of all these symptoms that they might potentially finally be diagnosed.
Yeah, exactly.
It's such a tricky thing because it literally can present differently for everyone. I mean, I've seen patients that have severe endometriosis and they didn't really recognize that the symptoms that they were having, if they had symptoms, they didn't recognize that they were abnormal, or sometimes they don't have pain. And then I've also seen the opposite, where people are having severe pain and we do surgery to look and see if there's endometriosis present, and it's not as severe as we would think. It's so interesting. It's a very weird disease.
Yeah, and that's what makes it really challenging to treat, and for the patients who suffer from endometriosis, why it's so frustrating, because the way endometriosis looks in somebody's abdomen definitely doesn't correlate to how they feel. Similar to what you said, I've done C-sections for patients, and you get in there and you're like, oh my gosh, it's like, how many surgeries does this person has? It's like, it's plastered, it's a mess in here, and it's just endometriosis. And then afterwards you talk to them and they're like, yeah, my periods are a little painful, I guess. And then on the other hand, I have patients who are crippled by their periods, who miss so much school, who, are super depressed because they don't understand what's wrong with them. And then when I scope them, I see maybe like one little dot of endometriosis. But, and especially in adolescents, endometriosis can actually look different than it does in adults. So I always tell my patients before I take them to the operating room for their diagnostic surgery, just kind of what I do a little bit differently compared to an adult surgeon, just because I do know that the endometriosis can present differently.
So talk a little bit more about that. How does it present differently in a younger population?
Yeah, so in younger patients, kind of like you were also talking about, in adults, we usually hear about infertility, maybe dyspareunia, pain with intercourse. And my patients aren't necessarily trying to get pregnant or aren't necessarily sexually active. They're biggest complaint most of the time is that their periods are so painful that they're missing school, they're unable to get off the bathroom floor, things like that. My approach to treating them is starting with the basic scheduled NSAIDs, talking to them about hormonal management, and then if after 3 to 6 months of that sort of typical treatment, they're not seeing any improvement, that's when I start to really think about endometriosis and kind of stepping up the treatment game and perhaps doing a diagnostic surgery.
So the first line treatment for that kind of like bad painful periods is like ibuprofen or Advil, naproxen, and hormonal, so like birth control pills?
Definitely. Yeah. So with an adolescent population, it can be challenging because you're not just making the decision with the patient, you're making a decision with the patient and their parents. And oftentimes when parents are bringing their kids to me and I start talking about birth control pills, you see their eyes get really big and they're like, but she's only 12. I don't want her on birth control pills. And so a lot of times we use a shared decision making process where I just kind of lay out the options and I tell them, I'm going to lay out all the options for you. It could be very overwhelming. Stop me if you have any questions about anything in particular, but know that these are just all options and that there's no right or wrong answer. It's just kind of like a choose your own adventure. So first line, I definitely recommend doing scheduled NSAIDs if that's something the patient can take. They're also welcome to alternate that with Tylenol if that's something that they're able to take as well. My preference tends to be for Aleve just because it's dosed every 12 hours. And for a teenager who's in school, that tends to be a little easier to follow than like the ibuprofen dosing. But everybody's different. Some people say that one works better than the other. And then I always talk about hormones as well. So if they are able to take estrogen-containing compounds, we'll talk about things like the birth control pill, the patch, or the vaginal ring. And then if not, we focus mainly on the progesterone-only categories.
And talk a little bit about why birth control pills are a treatment for endometriosis. This goes a little bit into the theories of how endometriosis happens, which in this conference I just went to, they talked about different theories for how endometriosis occurs.
Yeah, and that's always such a hot topic. Nobody really knows why, what causes it. There's so many different theories, with the most popular theory being retrograde menstruation. And that kind of goes along the lines of like those obstructive anomalies that I was talking about. If it can't go out the bottom through the vagina, then it'll go backwards into the abdomen. So by being on something like hormones or birth control pills or choosing to suppress your menses, it's essentially just preventing that pain, the pain with menstruation. It prevents any sort of endometriosis implants in your abdomen from flaring and getting worse and furthering that development. So early treatment is one of the ways you can prevent endometriosis from getting upstaged in adolescent.
And that's one of the reasons I really wanted to have you on the podcast, is I know most of our listeners are probably a little bit older.
Yeah.
But the more we can get the word out that, birth control pills are not just for preventing pregnancy. Birth control pills can be a treatment for so many conditions that do play a role in the future for your fertility. So it's not just about pain management, but potentially even helping your future fertility. If you manage these symptoms from an early age with something that is hopefully decreasing those implants, how extensively endometriosis might spread throughout the pelvis, that's going to be something that's really important for your future. And especially in our current political climate where there's concern that birth control might get regulated, it's really important to realize that controlling ovulation, controlling menstruation impacts so many different areas of the body besides just ability to get pregnant.
Exactly. And that's definitely a conversation I have on a day-to-day basis with my parents, where again, the most frequent concern is just the age of their child and kind of the perception that being on birth control might promote sexual activity, or that there's just kind of a minimum age at which being on these hormones is appropriate. They're worried about the impact on future fertility. But really, we use things like birth control pills, all the different agents. We use it not only for pain, but for heavy bleeding. Heavy bleeding is a big one too. So sometimes it can just be for their overall health. And like I said, if they're missing school, if they're missing activities, it's for their mental health and their overall well-being. A teenager shouldn't be stuck at home a week out of every month just because of their menstrual cycle.
Yeah, and we use the terms birth control pills or oral contraceptive pills or combined oral contraception, which puts the emphasis on the contraception, the preventing of pregnancy in the title. But really what it is just augmenting your hormones. So it's estrogen and progesterone or progesterone only. and that's augmenting things. So it's taking control and preventing some of those symptoms that go along with your period.
Yeah, exactly.
Yeah, sneak peek, one of our upcoming episodes is going to be a book review on all about the history of the birth control pill. I know I'm like halfway through, Ruby. I don't know where you are. It's a little bit dry, but it's, you realize all the PR stuff that went into it, calling it family planning, and you had to really, name this in a way that wouldn't scare people off of the idea of contraception, because it was so controversial when it first came out. But I do wish we had maybe named it just, hormone manipulator or something else that wasn't so keyed into that idea that pregnancy is the only thing that we're treating.
Exactly.
Hormonal regulation therapy.
Right.
One thing that I find interesting with endometriosis is that overall, when we find endometriosis, it tends to cluster a lot in the pelvis, but it really can be found lots of places, which is always so interesting.
And what makes it so confusing for people,
too. Yes. At this talk that I just went to, the doc was talking about finding endometriosis on lung tissue or microscopic implants in the brain. It was crazy. So it just makes you think, like, what exactly is happening here?
Yeah, I always tell people that whoever figures out what causes endometriosis is going to be able to retire real nice and early.
So what are some of the other symptoms that people can have endometriosis that may not be related to period pain and that might surprise people?
Yeah, so especially in our teenagers, patients who do have endometriosis tend to kind of have other conditions as well. They just they get grouped together. So the most common thing I'll see are migraines, which in selecting a method to treat the pelvic pain oftentimes will limit me. If they have migraines with aura, then I'm going to have to avoid estrogen-containing compounds, and then we stick more towards a progesterone-only type picture. So migraines, with or without aura, tend to be really common in patients.
That's such a hard combo too, because both endometriosis and migraines are things that you can't see it, and so a lot of people think it's all in your head, and you kind of have this stereotype that it's not a real condition. And so to have both of those together means you're having all these areas of suffering that society doesn't believe you.
Yeah, and it doesn't stop there. A lot of patients, in addition to endometriosis, migraines, they might have irritable bowel syndrome.
Oh, they have all
some
of it.
anxiety. Yep.
Yeah.
So by the time they come to me, these patients are incredibly frustrated with what they've been enduring for the past 1, 2, 3 or more years. They've probably already seen various other subspecialties. I'd say most of the patients who I see for this have already been worked up by a gastroenterologist. A lot of them have already been scoped from above and below, tested for H. pylori, all those things. I hope a lot of them do tend to already have a therapist, which is really helpful. Any patient I see for chronic pelvic pain, I recommend therapy for them and for their support network, because not only does this affect the patient, but it really affects the family. A lot of times the siblings who are seeing their siblings so incapacitated by this pain, that can also really affect them. So those are just some other things that kind of go along with endometriosis.
I'm also just imagining the family dynamics. I have a teenager myself, and they can be challenging. And so when you have someone that is just already doesn't want to get up, I can see how a lot of parents would brush off symptoms in the beginning and kind of think, well, you just don't want to go to school for XYZ, like, come on, you got to get going. And so then I'm sure there's a lot of guilt on the parental side as well when they realize, oh, wow, this really is something that my child has been dealing with that needs medical treatment, and I wish I had handled this differently in the beginning.
Yeah, for sure. And it's a very different experience for patients whose parents have endometriosis.
Yeah.
So we know that patients who have a first-degree relative with endometriosis are 7 times more likely to have endometriosis themselves. So sometimes, whereas the more common picture I see is somebody who's suffered from pelvic pain for so many years and now they're coming and we're talking about this, sometimes I'll have somebody who hasn't even started periods yet, but their parent had endometriosis. Their parents suffered through so much pelvic pain, struggled with infertility, got a hysterectomy as soon as possible because the pain was so bad. They're seeing their child go through early warning signs of puberty, and they're like, I don't want you to have what I have. And so they're coming to me sometimes even before they've started menstruating and are like, can I put them on the pill? That was the only thing that helped me with my periods.
That's true. You have these like 2 huge extremes of response. Either people don't believe or they're just waiting for that shoe to drop. And I think that's what we're going to focus on in that short snack too. So I don't want to ask too much about it now, but I know there are are some stats for like the average time from like symptoms to diagnosis, and they're always like really long and scary. Do you know what those are lately for endo?
Well, I know endometriosis generally will say there's like a 9-year delay to diagnosis.
Oh my gosh, that's
Again,
crazy.
it's different in my population
Yeah.
because these are population studies. So
Yeah.
this is talking about your patient in their 30s or 40s who's been having painful periods for decades and just been told, this is normal, or, maybe they got an ultrasound, like, oh, that's just that cyst, that can be really painful, or you're just being dramatic. But in my population, we usually have, especially if there's a family history, we have a short threshold to take them to the operating room and give them a diagnosis if that's something that they want. There's pros and cons to surgery. When we talk about diagnosing endometriosis, the surgery is just that. It's diagnostic. It's not intended to be curative. Sometimes it can help with symptoms, but I definitely present it as more of a diagnostic surgery and not something that will cure the pain completely.
And that's a really important point, because a lot of times it's not something that you have to have. Like, a lot of times we're kind of making a presumptive diagnosis based on someone's symptoms, and then especially based on what you try for management and if it works. Because if it's helping, you don't necessarily have to go in there and do a surgery to confirm something.
Yeah, exactly. And that concept is one of the hardest things for some of my families and patients to grasp. Like I said, a lot of these patients come in and they've already seen so many doctors.
Yeah.
They've felt brushed off. They've felt completely disregarded. And I often will hear, I've seen X number of doctors and they've done absolutely nothing for me. So we're looking to you for help. Please help. And then I go back and I really go through their past history with them and try to show that, well, your first doctor puts you on birth control pills, and then they had you take those birth control pills continuously, skipping your period. And then you tried Depo-Provera for a little bit, and then didn't you get the next one on implants? So even though none of those helped cure your symptoms, all of those were in fact treatments for endometriosis, if that's something that you have. And by being on those treatments, again, even though your pain wasn't necessarily gone, it was preventing any potential endometriosis from getting worse in your abdomen. So sometimes walking through that, they're like, oh, okay, yeah, I guess they were doing something for me.
And I think we also fall in this trap, like as you had mentioned before, of just the way our healthcare system is set up. We tend to be like have our little specialties, and you will see GI and you'll see neuro for your headaches and all of the, and you'll have your counselor for your depression and anxiety and all these things, and not looking at things from a holistic approach. So tell us a little bit about the multidisciplinary approach to how you guys are treating pelvic pain and endometriosis.
Yeah, for sure. So we actually just started a chronic pelvic pain multidisciplinary clinic at Seattle Children's. And so far, the key players right now are myself with gynecology, and then we also have a pain specialist from anesthesia, as well as one of our pain psychologists. We just did our pilot clinic back in April, and we're hoping to switch to a monthly clinic starting in the next academic year, so in July. In the future, we really hope to add a pelvic floor physical therapist. We're actively searching for one, and that would definitely be something that my patients would benefit from. And, even down the line, maybe even including things like neurology or urology or GI, the common other players for these patients. So even though right now we don't have all those people in one place, definitely when I do my initial evaluation of a patient with chronic pelvic pain, I literally sit down with them with a blank piece of paper and I write down all the organ systems. So I'm writing down gynecology.
That is so helpful, because I think even a 40-year-old probably needs that, It's
yeah,
not
it's so funny because every time I do it, people are like, you should just make a handout out of this and then just hand it to them. But I think there really is a benefit to sitting down with a blank sheet of paper and then really saying, like, these are all the things, like when you tell me you have pelvic pain, when you point down in your lower abdomen and tell me like this hurts, I always tell them, like, it's not always gynecologic. It's not always your uterus. It's not always your ovaries, and so I make a list and I tell them like gastrointestinal, like genitourinary, psych stuff, musculoskeletal, neurological, and then I go through each organ system and the gynecology, obviously, and then I go through the different things that it can be, so that they have a wide differential diagnosis. And then usually, like, if they've already had tests done, I'll cross them off, or if we're planning to evaluate that, I'll like make like a little box, like a to-do list. So if, for example, if like IBD was on there. Like we're ruling out ulcerative colitis because there's a family history of that, and they're going to get a colonoscopy in a couple weeks. I'll make that like a little box under the GI mark. Whereas if they've had, a negative one, then I'll cross it off because we've already looked into that. And I find that it's helpful because again, it kind of validates the past providers that they've seen when they come to me feeling like nothing's been done. It's actually, well, quite a lot has been done. You can see it all, and there's still much to do. So I feel like people in general come hoping for a magic pill that's going to fix the problem immediately. And whenever I launch into a discussion of hormonal treatments, I always tell them that I wish I had something that would work immediately and that was 100% effective, but nothing that I talk about today will do that. Everything you're going to have to give a nice little grace period of 3 to 6 months, and you might never have something that's 100% effective.
As a list person and a box checking person, I just love that idea of writing things out because one, it's showing that you're listening to them because you're literally like writing down what they're saying and taking their history. But then you get that visual of, okay, yes, this is what's happening. And sometimes that visual of seeing everything in one, for the patient, they can see how everything connects, and then also like having those boxes to check. Maybe it's just me because I really love lists.
I'm a big list person too. I make a to-do list every single day, so that's kind of just how I function as well.
Well, I love doing it together because I feel like otherwise this is sort of what happens in medicine, except we expect the patient to be making their own list, and that's what can feel so frustrating. Is you feel like, well, who haven't I seen yet? What am I missing? And that shouldn't be their job. That's why they're coming in. They're having these concerns, and so to show that you're going to help put all this together and figure out the best approach, I think that's a great way to go about it, especially when you create it together. And that's what you talked about earlier too, that everything has to be this shared decision making. We've changed a lot in how we practice medicine. We're not as directive as we used to be. We don't just give everyone the handout and say, I want you to try this thing and come back in 6 months. So maybe talk a little bit more about how you make a plan when you're trying to figure out what the next steps are for treatment.
For sure. So when I have a patient with chronic pelvic pain show up, like I said, I go through all the lists. And for anything that just kind of pops out to me, I want them to address those concurrently. So I give them the little spiel. Yes, you might have a gynecologic condition, but oftentimes you'll have other things that will either affect my ability to treat it with certain types of medications, or you have other things going on concurrently that are making the pain worse, or maybe it's a different type of pain that you're just kind of perceiving as the same menstrual related pains. So the biggest thing I'll see that's going on hand in hand with just painful periods is constipation. I don't know why, but teenagers just really refuse to kind of just like admit to themselves that they're constipated. I'll ask them like, how often do you poop? And they're like, oh my God, I can't believe you just asked me that. And I'm like, do you go every day? And they're like, yeah, I guess. I'm like, does it hurt when you poop? Like, is it hard? Does it, I show them like the Bristol scale, and it's a very like uncomfortable topic for them. But, something as easy as increasing your fluid intake, increasing your fiber intake. You don't even have to start using the over-the-counter like Miralax and stuff yet. Like increasing just water, fiber, exercise, you can already fix your bowel movements. And I can pump you full of hormones, but if you're backed up, you're still going to have that pain. So
when I think about how hard it is to even talk about periods, and at least usually teenagers talk to their friends about their periods, I don't think they talk to their friends about their bowel movements. So You're right. I feel like people have no idea what a range of normal is there, and they also think, oh yeah, maybe it's just normal that it's once every 3 days and it's like terrible for me, and they don't understand. That's something we really don't talk enough about.
Well, yes. Their parents probably don't have the poop talk with them, right?
Exactly. With the little kids, they love talking about poop, but when you get to somebody who's menstruating, it's one of those taboo topics.
Yeah, because I was just thinking, like, my boys, like, it's every 15 minutes they're talking about something related to poop, and I'm flashing back to like my pediatric rotations because I think I still have the Seattle Children's Protocol for constipation treatment printed off somewhere. It is so common in kids and teens.
Yeah, and that's definitely something because, if we're saying the overall goal, let's just pretend like, this person has endometriosis, I'm going to take them to the OR, we're going to go through all the different medicines to kind of treat that. Well, doing a diagnostic laparoscopy in somebody who hasn't stooled in 5 days really isn't that great. I can't see what I need to see from that. So I want to treat all of these things concurrently because it makes my job easier as well, and definitely helps the patients for the patient's pain. While they don't want to talk about their poop, they are actually quite forward in talking about their mental health, which I think is really great and something that's really different than like when I was going through medical school and kind of talking to patients then. Now our patients, a lot of them are very open about their anxiety, their depression. A good portion of them are already plugged in with counselors, therapists. If they don't have one that they see regularly, sometimes they can see their school counselor from time to time. And that support is really great because, like I said, anybody who has chronic pain is going to need that extra support. And there are lots of ups and downs in the treatment of chronic pelvic pain. It's not like this linear, like, oh, it keeps getting better, better, better. Sometimes you'll have some improvement, something might happen, and then, you get this huge setback. COVID, for example, was a huge setback, not just from a mental health standpoint, from a physical activity standpoint. You had a lot of...
That's true. All the sports were canceled.
Yep.
Oh, yeah. I never thought about that.
You had a lot of patients who, sure, I was treating them for their painful periods with like continuous pills or Depo or whatever. But then COVID hit, and then suddenly they're stuck at home. They can't play their sports.
They're probably not eating as well.
Yep, they're not eating as well, and
they're not drinking their water because they're not playing their sports, and that's the only time they drink water.
Exactly, and suddenly they're wanting to see me via telemed because their pills aren't working anymore. And it's like, okay, well, I mean, maybe it's possible. Sure, your medication can not necessarily work forever for you, but you also have all these other factors. And interestingly, like with the return to school, as things with COVID got better, you had these kids who used to be super athletic, who would practice 3-4 hours a day, who then had like 2.5 years of a more sedentary lifestyle. They go right back into it thinking that, oh, I'm just going to practice like how I did before. And then they're pulling muscles, they're not stretching, etc. And again, blaming it on their pelvic pain when, like I said, it's a huge multifactorial picture to look at. So every visit that I have with these patients, I'm always touching on each organ system just to make sure there isn't something else that we need to look at.
So besides the constipation piece, what other lifestyle things do you kind of talk about with everybody?
Starting just in the GI category, definitely constipation is bigger. Notice like food triggers for people who have sensitive stomachs. I feel like everybody these days has already been tested for food allergies. So a lot of times I'm cheating when they're like, oh yeah, here's like my tests, all my testing that I got. I'm like gluten and lactose sensitive, or I'm fructose insensitive, something like that. But definitely from a GI standpoint, looking at bowel habits, food, water intake. From a genitourinary standpoint, we still talk about like the rule of two. So I'm kind of like you do with a little kid, going to the bathroom.
Yeah, break it down. What's the rule of two?
Yeah, so I mean, especially like in school, right? A lot of times you don't have all the time to go to the bathroom. You might be limited in like your bathroom passes. People tend to hold it. And so the rule of twos would just be, going to the bathroom every 2 hours, whether or not you want to. The other parts of it are kind of more from...
Man, I can't even imagine that from being a nurse so many years. I know they have like nurse's bladder and teacher's bladder and all the when you're not allowed to leave a room for...
Or you get a busy clinic day. I'm just like, I don't even follow that rule.
I always feel like such a hypocrite whenever I talk to people about that. I'm like, yeah, you should go to the bathroom every 2 hours, even if you don't need to. And I'm like, when was the last time I went to the bathroom?
Have I gone to the bathroom today?
Well, and I know also in some of the pelvic floor classes that they talk about it's bad to do the just in case peen, which is especially when I had little kids, it's like, oh, okay, before I sit down to like nurse me, I have to pee first because otherwise I might not get up so I definitely am in that habit of like, oh, I'm about to leave the house, I better pee first. And then they say that's not good for your bladder and how you train things either. So.
Yeah. And then I know we talked about kind of endometriosis as friends, and interstitial cystitis or IC is also one of the things that we frequently see with endometriosis, which again is kind of one of those frustrating conditions with a delayed diagnosis. Some people don't even like quote unquote believe in IC. And so it's just, again,
explain IC. What is IC?
Well, I by no means am an IC specialist, but it's painful urination, just kind of that sensation that, there's a pain down there and you just got to go all the time. And, these people will oftentimes have negative urine cultures, negative workups, that sort of stuff. So just again, another frustrating chronic pain condition. One of the things that I tell my patients just to try empirically is an IC diet. So if you literally just Google interstitial cystitis diet, there is a list of like food triggers that have been known to trigger interstitial cystitis. And so it's just kind of like an elimination diet approach. And like from the GI standpoint, I oftentimes will say, why don't you just give like the FODMAPs diet a try? Just kind of, again, trying to put these cleaner foods into your system that won't trigger these other things and see if it kind of makes things better.
And I'm thinking about like what goes along with endometriosis and interstitial cystitis, IBS, some of those inflammatory things. So
Yep.
inflammation is kind of common among all of them.
Yep.
So if we are addressing inflammation with lifestyle, that can be pretty beneficial for no matter the source of the pain.
Yeah, definitely. And, diet is a real easy one to kind of target again for these patients. Again, we're thinking like list people, right? Like if I'm at this point where I'm so desperate, I'm in so much pain, give me a list of things I can try and I will do them. And so if I have to try different diets, sure, I'll try this for how long do you want me to try it? Give me, 3 months? Sure, I'll do that. But, other lifestyle modifications you can do is really just incorporating some stretching, especially if you aren't necessarily the most active person or getting back into activity. Make sure to do some stretching before and after, kind of treating any sort of muscle sprains appropriately, just not kind of pushing through them, that sort of thing. And we've already talked about, therapy, but like mindfulness, yoga, just things to kind of reset in that way. I'm always promoting those with my patients.
And do you like to have people journal to like kind of try and look for their own triggers, look for their own things that can often be helpful or set off symptoms? So how do you have people kind of take a hard look at their life?
Yeah, so teenagers are historically terrible historians.
Oh, I love teenagers, though. That's the fun part about teenagers is like trying to get a history out of a teenager is so challenging. Yes. But I loved it when I was going through training. So I'm like, I'm just getting a yes and a no and looking at the wall from you, and I find it the challenge fun.
It's like pulling teeth, and then you are just like, sometimes things are just so literal, and you're just like, okay, like for when was your last period? Like, I don't know, like the day before the football game. I'm like, well, when was the football game? Oh, it was the weekend of my cousin's birthday. Okay. When was your cousin's birthday? Like, help me out here.
It's doing a little logic puzzle. That's good. You gotta have it.
Exactly.
Keeps you sharp.
Yeah, so usually I love when patients come to me and they already have a pain diary in place. And that's usually what I'll tell referring providers. Like if you're sending a patient to me because you're concerned for endometriosis, please have them start essentially journaling, but like keep a pain diary in terms of like when you have the pain, where you feel the pain, what was kind of going on. Did you have a bowel movement that day? Did you eat certain foods? Did you have like late night fast food before that happened? And a lot of times by the time they see me, they've already kind of identified some things. And they're like, yeah, my pelvic pain kind of flared up every time I ate gluten. So I stopped eating gluten and I feel a little bit better, but it's still there. So yeah, not necessarily journaling, but yeah, kind of keeping track of the symptoms. But it would be nice to kind of throw in the kind of the psych aspect of that. Like if they had a fight with their partner or their family, if they were stressed about finals, they had a big game, something to think about like that would be something I should add to my pain diaries.
We've talked about this a little bit. You mentioned how people often come to you already doing so much research, and that's good and bad with the fact that especially in a younger audience, so much of that research is coming from social media. So I wanted to talk a little bit about your thoughts on the fact that especially a lot of celebrities have been more open lately about having endometriosis and what their approach was. Like, what do you see in terms of how the awareness and the source of the information has impacted your clinical practice?
Yeah. I think it's great that people are talking about it because like we said, for so long, we've just been told your periods are supposed to be painful. This is normal. Just kind of suck it up, essentially. So it's great to see so many individuals with this social platform being like, no, it's not normal. I suffered through this for this many years, and this is what I ended up having. A lot of them are very vocal about their infertility struggles too. And I think that's important for our patients in their adolescence, especially if they see themselves as somebody who down the line would want to have a child. Just kind of knowing that this could be a potential thing that they have and that they could act on it sooner rather than later. I think the biggest downside is because these people coming out and talking about their endometriosis are adults, it's really not appropriate for an adolescent population. Like the curative surgery that some of these patients get is not available to our patients, where I'm saying curative surgery in like air quotes, because, a lot of the times patients and their adult patients with endometriosis end up getting a hysterectomy for it. And I'm not going to offer my 14-year-old who hasn't even had the opportunity to bear children, if that's something they wanted to do, a hysterectomy to kind of help with their pelvic pain.
But do people come in asking for one? I mean,
Yeah. I mean, I do have patients
I
saying
was
like,
going to say, yeah, I remember being 16 and being like, I am not going to have kids, so I don't care. Just take my uterus out, so.
No, I definitely have patients who are just kind of at the end of it. They feel like they've tried everything and they.
well, chronic pain is terrible. I mean, you
Yeah.
think about it for this amount of time and how it impacts your life. I mean, I can see how it's hard to think about a future you and what you might want when you're dealing with something that's so debilitating in the moment.
For sure.
How do you have that conversation? How do you kind of talk about other approaches and a long-term view?
Yeah. Well, I think the good news is there are so many options when it comes to treatment. And so definitely it is a little more challenging when someone comes in hot and is just like, I've self-diagnosed myself with endometriosis. I want a hysterectomy like Lena Dunham had did. That's the only thing that helped her. I don't want to have kids, etc. I usually will sit down and just say, again, everybody reacts to medication differently. I love making my list. So what have you tried? Tell me what medications you've tried and for how long and why you discontinued them. And oftentimes we'll find like, oh, I tried this birth control pill and I stopped it after 2 weeks because I felt moody on it. 2 weeks really isn't like long enough to see the benefit of the hormonal contraceptives. So then we talk about hormonal contraceptives that may also help with things like PMS and PMDD. Are you willing to give that one a shot and see if that, will help your symptoms in addition to targeting the things that were problematic with you before? Somebody who just gets one shot of Depo-Provera, I mean, we all know it usually takes like 2 to 3 shots to really see kind of the full benefit of menstrual suppression. So when you tell me you got one shot of Depo-Provera and you stopped it because you didn't like the irregular bleeding, that's not exactly a fair shot, no pun intended with that. But, I kind of encourage them, are you willing to kind of revisit that? And then kind of really my big gun medications for somebody with chronic pelvic pain who I'm concerned about with endometriosis, I'll talk about things like Depo-Lupron. And, I don't take Depo-Lupron lightly, right? Because it's a big medication that essentially shuts down your hormones from the brain down. I tell them it's like a chemical menopause. But for patients with endometriosis and chronic pelvic pain, it can really just be a nice breath of relief for them. I don't use it long term. I tell them it's not intended to be a long-term medication. Most people will only use this medication for 6 months in adolescence. I personally feel comfortable using it for, a year in patients where I really have a high suspicion that endometriosis is the culprit for it. But, it's a medication with really terrible side effects like hot flashes, vaginal dryness. You want to talk about mood swings? I mean, those menopausal mood swings, but it really can provide a nice relief for patients with pelvic pain. And then there is the medication Orlissa, which is an oral medication that's for endometriosis. There are other options, and we just kind of go through everything. And most of the time, these patients who come in hot asking for a hysterectomy haven't gone through all of that yet. And depending on how old they are, we might actually talk about something like fertility preservation or what the options are if down the line they did decide to remove their uterus, but they still wanted to be parents.
One question I have is, and we maybe should have covered it at the very beginning, but how is endometriosis diagnosed formally?
Yeah, so endometriosis is only formally diagnosed surgically. So it is a surgical diagnosis, but it can be treated empirically through just the clinical presentation. So I don't necessarily need to drop a scope in your abdomen to treat you for endometriosis. And especially in adolescence, the treatment options for somebody with painful periods because of something else other than endometriosis are the same exact things as somebody who does have it. So really the only way we can do it is just by taking a look in the abdomen. We do a really thorough survey of kind of the popular places where endometriosis can hang out. Maybe not take some biopsies if anything looks suspicious, and then it's a pathologic diagnosis when it comes back and it says endometriosis.
And it seems to me just like intuitively that it would be much harder because if someone's young and they haven't had the 20 years of time that some of our patients have, like when you're doing a surgery, maybe you don't find implants, but that doesn't necessarily mean that it couldn't be going on, right?
Exactly, which is why like some patients really want the surgery for their peace of mind. And I always mentally prepare them by saying like, okay, well, also give yourself this scenario. What if I take a look inside your abdomen? I take a real good look in every nook and cranny. I take some biopsies and it comes back clean. How will that make you feel? I'm not here trying to make you feel like you're crazy and that this is, just in your head. I'm still going to treat you the same exact way. Really kind of where I like to move towards surgery is if there's something else that would take me there. Like if, on ultrasound, it showed that they had an endometrioma that needed to be removed. Of course, I'll go ahead and do that. And then I'll also kind of take a look in other places and take care of that for you. Or if they were interested in getting an IUD placed under anesthesia for menstrual suppression. Usually patients who find themselves in that boat have already tried cyclic pills, maybe continuous pills, maybe a few months of Depo-Provera, and they're ready to get the IUD, but aren't necessarily a fan of the in-office procedure. So we'll place an IUD under anesthesia and then take a look up top for endometriosis, since it's also an opportunity to place a device that can help their endometriosis from worsening.
That's a great option to bring up. I don't think enough people are aware of that.
Yeah. That's such a good point, is because I would never thought of that, because I am kind of a data person. So if it were me, I'm thinking like, well, I want to know, do I have it or I don't? But that's such a good point that it can affect, if you don't get that answer, then you're kind of back where you started, and maybe in a place that it's even more difficult because now you're questioning yourself. So that's really good discussion of whether surgery, it might not be the best thing for some people, but then you have opportunities for potential things like IUDs as well.
Yeah, which is why I try to correct the other concurrent factors, because sometimes people are like, yes, I want the surgery. And by the time they get scheduled, they've also been working on their bowel management. And I've had people cancel their surgeries like a week before. And it's like, I haven't had any pain in the past month. And I don't know if it's because of all the exercise I've been doing or the bowel management, but I don't think I need the surgery. I'm happy with how I am.
Do you go in sometimes and there's no endometriosis anywhere, but they are so full?
Oh, that is
like, I think I found the problem.
Very common. It's very common.
Oh my gosh. Yeah, I don't think people realize how significant constipation is. It seems like, it's such like a, something that happens that nobody talks about. It's not a big deal. It's just constipation. But how debilitating it can be, and how much it can really mimic other things and make it really challenging to figure out what's happening.
For sure. Yeah. I put everybody on a bowel regimen.
Everything comes back down to poop.
Yeah, it does. It really does. It really does.
Perfect.
Okay, well, we covered so many interesting things. Thank you so much for being with us today. Anne, is there any last burning questions you have?
No, I think you've done a great job also highlighting the hope that's here. I feel like you said in the beginning, maybe people come in to see you already in such a place of frustration where they just haven't been listened to, feel like they haven't been taken seriously. So I think just hearing, even in this brief talk, how many options are out there, but also setting those expectations of needing to take time, needing to take an individualized approach, needing to address all these body systems. I think it's great that you have this new clinic. I think it's going to be such a wonderful resource to take more of that multidisciplinary approach. And I really appreciate you coming to talk with us today.
Yeah, thank you for having me.
Thanks for joining us for this week's episode of the Whole Pineapple Podcast. We hope it was helpful.
If you know someone who could benefit from hearing the podcast, we hope you'll share it with them.
And don't forget to subscribe, rate, and review The Whole Pineapple on your favorite podcast app. Every rating and review makes us easier to find.
This podcast is sponsored by Seattle Reproductive Medicine and is produced by Audiotocracy Podcast Production. We'll see you next time. Have a delicious week.